intensity among orthopedic patients in post-op care. And I'm just going to say, let's keep time.
Okay, sure.
Yes, welcome.
Sure, are we? Good afternoon, everyone. It's really nice to be here today. I'll be presenting on the topic, I'll get through this, moderating role of pain resiliency on the relationship between pain catastrophizing and pain intensity among orthopedic patients in post-operative care. So I'll start with an illustration. Imagine a mother that wakes up every morning, tries to comb through the daughter's hair, and then she screams. And then when the father takes the comb, she stops screaming. The mother takes the comb back, she starts screaming again, and then the mother just decides to rub the comb just over her hair. The daughter thinks they're still combing her hair, and then she's screaming, and the mother was like, I'm obviously not the problem here. So in such situations, or putting it down to my topic, orthopedic surgery is screaming, I'm totally not the problem with the patients not recovering very fast. There might be a problem with the patient. If they are having an overstay, there's obviously something wrong. So postoperative pain is a prevalent global medical issue. Obviously, anybody who goes through a surgery, they will have to stay over for a while. Okay. They will have to stay over for a while in the hospital. They are not just managing the recovery, but to make sure that the level of pain is also going down. And being that orthopedic surgeries, they come with this level of limited mobility after them, they can affect a lot of things, especially the person's psychological states, and then this can also increase the level of pain. And then after reviewing our studies, we found that a lot of factors can contribute to the level of post-operative pain, including age, gender, level of education, prior surgical procedures, and also history of mental illness. And then one mental health challenge that can actually affect the level of pain being felt by patients could be cognitive distortions. And cognitive distortions, they obviously amplify the experience and the perception of pain by patients. And one of such cognitive distortions is pain catastrophizing. Pain catastrophizing can be described in 3 different dimensions. The first is rumination, which is the repetitive thought about a particular thing, or in this context, repetitive thoughts about the pain. And then magnification is over-exaggerating the pain being felt. And then helplessness, that is feeling like they are not in control anymore of their body, the movement, and every other thing involved. That is helplessness. So studies have actually proven, with the studies reviewed, that pain catastrophizing, it contributes to increased level of pain intensity among different surgical patients, even patients in the hospital for other reasons like cancer and all of that. So we also go forward and said, pain resilience, it focuses on the ability of individuals to manage and cope with this pain. And studies have proven that resilience alone, not pain resilience alone is a factor that can help patients to recover. It also shortens the length of stay in the hospital across different groups of patients. What is not known? Will pain resiliency moderate the relationship between pain catastrophizing and pain intensity? There is an already existing relationship between pain catastrophizing and pain intensity. So we are checking, will pain resiliency increase or decrease this relationship? That was actually what I investigated. And then for our participants, there were 352 orthopedic patients under post-operative care. And then they were selected using a purposive sampling technique, and their age range was 26 to 43. And one significant observation I had while I was collecting my data was that who you are to the patients matters, how they respond to the questionnaires. Because at first I was coming and then I'll tell them I was just a researcher, and they were like, please, the pain is too much for a researcher. But then when I came back with some healthcare personnel, they thought I was part of their people taking care of them. So they were willing to respond to the questionnaire, and they were giving their sincere responses. And then I was like, okay, I'm a clinical psychologist, you might want to do this. So they got more interested. And then our instruments were a numeric pain rating scale, pain catastrophizing scale, and the pain resilience scale. For our data analysis, we used the highest regression-based process macro. Our findings, higher level of rumination and helplessness were significantly associated with increased pain intensity levels among these patients. And then higher level of pain resiliency was significantly associated with decreased pain intensity levels among the patients. And then to the main finding of our study, only Only rumination moderated the relationship only resilience moderated the relationship between only rumination and pain intensity levels. The other two, which is magnification and helplessness, they were not significant. And then for the finding, we found that people with moderate and high levels of pain resiliency, they reported a decreased relationship between the rumination level and their pain intensity level. Implication of our study findings: we have to incorporate more CBT techniques, such as cognitive restructuring, to manage these negative thoughts towards pain. Just like Angela said during their panel discussion, you must not be a therapist to offer therapeutic services. That means that other healthcare professionals, aside from clinical psychologists and the psychiatrists, should be trained as well on how to offer these services. And then going further, there should be an enhanced communication between healthcare providers and patients. It's very crucial. And this communication, starts from informing the patients properly about the surgery, what to expect, what is going to look like before and after the surgery, what the outcome of the surgery would look like. And when this is done, the patients should also be encouraged to practice care practices such as relaxation techniques, mindfulness practices, and stress management techniques. This is on the individual level when it comes to the part of the patient. And then finally, inclusion of family members and caregivers in pain management education. This is very important for me because I know I used to have a friend, whenever we are going to write an exam, and I'll tell her, okay, we are preparing for this exam. The first thing she will tell me, nobody passes this lecturer's course. How do you expect me to go into the hall? Of course, I'm going in with the mindset that this is going to be tough. So the family members are like the closest persons to the patients. We need to train them. They need to also know what the surgery is about, because they've seen some other people that had the surgical experience. Everybody's surgical experience is different. Just because someone's own came out this way does not mean the patient's own will come out that way. And then the family could be promoting and be like, okay, you're going to be limp after, you're never going to work after this, you're not going to use your hands after this. Because they might end up listening to the family members more than they listen to the healthcare personnel. So we must really get to include them in our practices. And also what they tell them matters a lot. In Igbo, there's something we say, we'll be like, onye duru ka na-edu. What it means is someone who perseveres, that we encourage. Now, imagine a family member coming up to tell the patient, it's the way you help yourself. You need to help yourself so that we can actually help you. You need to help yourself so the doctors will know where to come in from. Imagine that coming from a family member. Imagine that coming from a caregiver. And this can only happen when these people are highly informed about the surgical procedures they are about to go through. And then going further, after conducting this study, I was like, it doesn't end here. More has to be done. I've actually started some, but I'm actually still calling out for some collaborations. The first one is to replicate the study findings in other African countries, so as to investigate the trends for a systematic review. We can actually go ahead to conduct a systematic review. You check if this is also similar in your own country. I check whether this is also similar in my own country, and then we can publish a systematic review. We can also conduct a study to investigate the effectiveness of resilience building interventions. This could be cultural based and all of that. We could conduct studies on that, so I'm open for collaborations. And then we could also conduct study on the influence of preoperative resilience training on these postoperative outcomes. And then finally, we could conduct studies on comparative studies across different types of surgical patients. I'm very open to this. Thank you very much.
Thank you, Doris. That was quite amazing. Anybody who has a question for Doris about pain?
All right, thank you, Doris, for your presentation. I think I'm actually quite interested in it because I have a background as a physiotherapist. And then I know that, so my first question would actually be that when you actually looked at your patients, post-operative care, orthopedic patients, did you exclude or did you look out for co-founders like their pain threshold? Because we know that people have different pain threshold. And then it's said that, for example, in Nigeria, those who are of the northern tribe, that's the Hausas, actually have a high pain threshold compared to other people from other social demographic locations. Then also too, I don't know, I'm also wondering, if your patients were a study participant, was there anyone also with a limb, maybe an amputee or something? Because there is also this phantom limb pain also. And so what role does that also play also when it comes to the pain catastrophizing also? Then, okay, for the recommendation part, we actually talked about the preoperative pain resiliency, and then looking at that, I actually think that's actually something that should actually be studied too, because I know that when people actually have very good holistic preoperative care done, it also helps them to well post-operatively. So I want to know, did you look at that pain threshold, phantom limb pain, in looking at the pain catastrophizing and then the pain intensity too? Thank you.
Okay, thank you very much for that question. We didn't investigate it in this study, but there's this other study that we are also collecting data for currently among a different group of patients, where we are investigating special factors that contribute to pain catastrophizing. Do you understand? Like this study was just something we came up with for my MSc thesis. So we just collected the data around the variables that we needed. It was after we were done that we were like, more should have been done. More data could be collected to investigate the pain catastrophizing. It became more interesting to me and the pain resiliency. So that's why I'm calling for further collaborations and research.
Thank you. Thank you. One last question before we move on to the next. Anybody else?
Okay.
Thank you very much. My name is Patience. You talked about the level of education affecting pain resilience.
Yeah.
Could you throw more light on that? How does it work?
Okay, the level of education, first of all, for people who are more enlightened, who